So we have someone else in person. So I'd like to invite Tasnim. Tasnim Zara, can you join us? And then we've got a sort of a hybrid model today, which reminds me of my teaching and learning during COVID. We went simply into hybrid model, which was in person and online. And I'm very glad that we have this very dynamic young woman leader with us today. We also have the Associate Director of BRAC's Health Program and Dr. Richard Cash from Harvard, who has a long history with Bangladesh since the 60s. So I'm going to get to the point because Richard is going to be leaving us earlier. As what happens with very exciting conferences is we have a lot to share. So we never can stick to time, which is fine, because we want to hear more. And I'm going to go and ask Richard the first question rather than give you introductions, because I think everybody has some of the documentation of who the speakers are. But just to say, Richard, hi. Can you unmute yourself? Have we lost Richard?
You are muted now. Press.
Hi, Richard. How are you? What time is it over there?
It's now about 7:30 in the morning.
Wow. Did you go for your morning jog?
No. My morning wake up is what I did.
And we have also Dr. Morseda, who's joining us from Australia. What time is it over there?
It's 10:30, Sabina.
Not too bad. Our debrief, it was midnight for her. Okay, so Richard, what's really exciting, and I've been sitting in the audience, is I think the human spirit, the commitment, the solidarity, and just hearing from many interesting speakers. And given your long history with Bangladesh, I wanted you to speak a little bit briefly about frugal innovations or inclusive healthcare systems and what Bangladesh can or has been leveraging that we don't talk enough about.
Well, I think that, and Bangladesh, in some ways, is a model for some of the issues I'm going to talk about. I think that the key here is how to get care and prevention into the community, and that requires very much the use of community health workers and what they can do. I think we saw during COVID that really the frontline workers for the vast majority of cases were in the community. They were the ones who could spread the information. They were the ones who could provide care. Most of the tertiary care that was introduced in the West, frankly, was not very effective. It was highly expensive and certainly wasn't very available. And I think the key here is finding innovations that are attainable, that you have to be able to get them, and sustainable. And I think that is the direction that frugal innovation must move towards and has through the use of community health workers. So and they come in various forms and various programs and so on, but going to the community and addressing these issues in the community are what is critical.
I know, Richard, that social justice and equity is a big issue when you're talking about inclusive healthcare systems and community health workers. Can you give us a specific example, because we have a very diverse audience here, of when we say we want to improve by leveraging community health workers and how that would actually achieve equity?
Well, I think certainly the most obvious form of equity is mass immunization, getting people immunized, because that immunization truly is an equity directed intervention. My own work going back many years, the use of oral rehydration therapy, of course, is another example of creating equity, because it provides people with a form of therapy within their home that they can use in their home. Social justice and equity are critical to any health programs that are trying to improve the health of the citizenry, of the population, and has to be foremost in our mind in any intervention that we propose. So those are two examples that I can
Thank
come
you,
up with.
Richard. So I'm going to break it up a little bit. Before I come to Dr. Morseda, who work closely with the government and NGOs, I want to ask our young dynamic leader who set up a startup, and you were referred to earlier, and I think it's really admirable because we know that social misinformation, along with good information or accurate information, was rife in social media. This was not a problem just in Bangladesh, but globally. In fact, one of the new things we're talking about in public health curriculum is how do we improve risk communications. Can you tell us a little bit about what made you, decide to work on this, and what did you do, briefly? Thank you.
Thank you. Thank you so much, Sabina Appa. So, as we have as it has become clear through the day that digital transformation has been accelerated by COVID pandemic at a pace that would probably not have happened otherwise. And the healthcare and health system has not been an exception as well. If I set the context a bit, so in an urgent healthcare crisis, the first thing people need is correct information. What is it? How does it spread? How do I protect myself from it? When do I go to the hospital? But as the pandemic started, and I was working at a hospital at that time, I saw that social media and the internet in general was filled with fake remedies, fake news, and health misinformation. And this was not only posts without names or faces, this was also coming from experts sometimes when they were trying to be reassuring, but they were speaking without evidence. For example, early on in the pandemic, we had a few experts telling us that COVID's not going to affect Bangladesh because we've got a warmer climate. And then later on, we saw some doctors advocating and recommending plasma therapy without evidence of it actually impacting COVID treatment. Now, apart from experts, sometimes misinformation is also shared by people we love and who love us on WhatsApp threads and messenger threads. They don't realize that it's inaccurate and they only share it because they think it's going to help us. Now, that's this problem, but if we talk about whether it actually impacts people's lives and decisions, or does it only stay on virtual screens, we've had multiple research showing that it is detrimental to people's health in general. And I'll just share a personal experience to kind of give a human face to the impact of health misinformation. I was working in the intensive care unit of a hospital in England. Some of you may know this as ICU, so this is a place in the hospital where the sickest people are treated. And a whole section of it was full of people who were suffering from COVID. And all of them were unvaccinated. So I was speaking to one of them, and he was telling me that he regretted not taking the vaccine because of something he saw online. And he was asking me if he could take the vaccine then, at that point. Well, at that point, he was hooked onto an ECMO machine, which is one of the most intensive forms of life support that is available, and it's only available in very few hospitals in England. And I had to tell him that the COVID vaccine is not going to protect him now. He's got severe COVID, and it's too late. It was heartbreaking, and he ultimately passed away. But this is just one story of how damaging health misinformation can be. So in this context, I thought that one potential solution can be making reliable health information available online in a language people can understand and easily remember. So that's where we have that concept of making brief videos, sharing reliable health information, which people can use in their daily lives. And I thought of social media because these are the platforms where misinformation is spreading, and if people can have reliable health information side by side, that can make them pause, reflect, and ask questions. And this is something we're now trying to do from Shohay Health, not only on COVID, but also on other diseases. And people do actually want correct information. They appreciate reliable health information. People are watching the videos in millions. Our website is visited by over 300,000 people every month. And we also try to partner with organizations to reach people who do not have internet access. We partnered with BRAC early on in the pandemic to train health volunteers on the ground. We had partnered with Grameenphone, who's the largest telecom operator, who distributed those contents.
I'm going to steal the mic.
Yeah, sure.
I think it's fascinating because we all lived through this. We didn't know what to do. We didn't know what was the right thing to do. We wanted to save family members, and we were really confused and panicking. I think it's remarkable, and I'm assuming the videos were in Bangla and English, so it's accessible. I'm going to come back to you because, Richard shared some very important points of community health workers are often the bridge to the communities, and we often forget them, and we need to kind of invest in them. And I'm going to come back to that. But I want to ask Dr. Morseda, because she's Associate Director at BRAC's HNPP program, and there must have been enormous stress. There's COVID, there's lockdown. You have to figure out strategies, talking to your colleagues, talking to the ED, but trying to figure out how you, as a health program, can contribute. Can you tell us briefly about these sort of partnerships and how it evolved?
Yeah, thank you, Sabina. Yeah, it was very hard time for us, even for our community health workers. Currently we have 50,000 Shasta Shebika and Shasta Kurmi altogether. And we have to decide that, we had to decide that whether they will be working at that time or not, and how they will be working. So we have figured out that we have to protect them first, and then give them proper instruction that how to they go to visit the households with keeping social distancing. And they kept their work, like giving the right information, as Tasnim Jara was saying, that giving the right information at that time was very crucial. And they kept that doing with proper guidance. That means keeping themselves safe and also maintaining the proper distancing. So, a recent, at the time, there was a big study by Yale University, and it found that, if mask distribution can be done free, and it is reinforced repeatedly, then mask use can be increased by 30%, and infection rate could be reduced by 9%. So we kept this mask use, mask wearing intervention through the health workers and all the non-health workforce in the field. Four measures like mask wearing, hand washing, social distancing, and vaccination. And on top of that, we also did other innovation, like frugal innovation, we could say that we build resilience in the community. That means we use the community clinics and community clinic support groups and local leaders, so that the community is resilient and they can be capacitated. And if when any form of virus hits, they can act upon themselves. Because we know that this virus is ever changing, and if we wait for someone to come and help them, it would be too late. So the community should be capacitated enough so that they can act upon very quickly, and now the community can help themselves.
Okay.
And another innovation was that the health workers and volunteers help the people for vaccine registration very quickly and act on preventing, debunking the vaccine hesitancy. And Tasnim Jara was saying that she observed it in her country, but in our country, we really could debunk it, and people, there was less vaccine hesitancy because we could really quickly act on it. And
So Morseda, I'm going to
yeah.
come back to you for a minute because I know Richard has to leave earlier. But I think the key messages we're hearing, and if I think about, reflect earlier on in the afternoon, is there's a lot of, if there's commitment and you're leveraging community health workers, you're actually putting communities in the forefront to being their own active agents. So there's a lot of trust and relationships that BRAC and many organizations already have. And I think what I'm also hearing is misinformation has to be dealt with directly. But Richard, I wanted to come back to you because I know you have overbooked yourself in a couple of meetings. But what would be your, you've lived and worked in Bangladesh a long time. And if you're going to think, reflect critically, because what they say with pandemics and crisis, that there's a selective amnesia every time it happens. So what would you say would be a takeaway message to, I don't know, global north, global south, because we do have many effective innovations in many of these countries in the developing world context?
Well, I was just thinking about your speaker who talked about videos and so on.
Tasnim.
You know, there was a I can't think of the name. It's based in India, a group that tries to tell farmers innovative ways of planting and so on, and have developed a series of videos that they give in the community through a very simple platform. Couldn't we do the same for health? Couldn't we put together 2 or 3 minute videos that could be used in the community, used by the community health workers, who are a trusted group, to demonstrate certain issues, to deal with the positivity of giving a vaccine? Simple messages, not complicated and so on, which we sometimes tend to do, but a very simple, and these would always be there, available to the community health workers, saying, well, let's take a look at what happened last year or the year before. So that's, I think, certainly one possibility. Clearly, I think what happened in Bangladesh for that limited vaccine hesitancy is that people were quite aware of the value that vaccines had provided in the past. They have seen tetanus disappear. They have seen measles disappear. They have seen the outcome of a very vigorous program. Why not reinforce that? And this one idea to use the community health workers and use the technology in a simple way to get the message out there. Not everybody has a computer. Not everybody has some place to look at it. Why not provide this?
Thank you, Richard.
One idea.
Yeah, thanks, Richard. That was very helpful and useful. I'm going to just, because we're kind of trying to wrap up and then we're going to open up to Q&A. It's been a long day, but I wanted to ask Tasnim that, you developed videos. What helped you focus on certain kinds of information? Secondly, what about marginalized groups or groups that don't have access? What would you do differently if this happens again, or add to?
We can share. One of the things that helped in trying to identify areas where we would make videos on was, during COVID at least, was the areas where misinformation was very rampant and the consequences are deadly. So things like vaccines, or how people can protect themselves from catching COVID, how to take care of themselves during COVID, and also echoing what Dr. Cash said, I think clear demonstration videos where we teach people practical things with step-by-step guidance can really help empower people, and that also plays a key role in helping people remember and understand key teaching points. So for example, early on in COVID, when we first learned that oxygen levels can drop without people actually feeling breathless, we made a video teaching people how to use pulse oximetry. And then we had many messages saying that they learned it from that video and was using that to monitor their relatives at home who were suffering from COVID. So it was basically these things where we thought it would have massive impact. And then later on, when we moved away from COVID, it was things where the stigma is probably very prevalent and people don't talk about them, things like sexual health, colorectal diseases, pregnancy. And to what we would add on, if it were to happen again, I think is also try and reach more people on the ground. So now we're doing a project with an organization called Met Global, who are using these videos to train female community leaders on breast cancer and cervical cancer awareness, who would then act as information hubs for their community. So I think we would use those models more to reach people who do not have access to internet or would not probably have smartphones, because in some households it's mostly men who have the phones or smartphones.
So Morseda, I wanted to ask you something, because a lot of the messaging was very focused on prevention but biomedical. And given you worked in communities and trying to get vaccine uptake amongst even marginalized groups and NGOs and government, and it was a very, very productive collaboration, what do you think could have been included or should be included in future messaging where you don't have water, where distancing is not an option when you have 8 people sharing one room in a slum settlement, where you can't actually wash your clothes every time you come and you only have two kurtas and 2 pajamas to wear? I'd like to hear from you, because you've been working in public health and I know you understand the human dimension beyond the biomedical.
Yes, this is the practical situation where we work, like in slum areas. It's really impractical to say to maintain social distancing when people, 7 people live in one room. So what we have to say is a very practical thing. What they have to do is prevention, so that they don't catch the disease. And prevention is very important for this kind of community where vaccination is very important. So we have to get them vaccinated. And the way we did it is we did registration, as I told you before, that they don't have access to smartphones. So active registration was the first thing. And the second thing was screening. So we helped them screening, and the tools we used for with the community health workers, that is also something very innovative, was digital tool. So community health workers used a digital tool which was very handy for health workers, and a very easy tool, and they could identify either a person is having a mild symptom, and they could have that test done, and the person could be referred very early in the respective health facilities. So in settings where certain measures like social distancing and hand washing, frequent hand washing is not possible, so this kind of intervention could be should be implemented, and we have done it. And telemedicine service is very important for them because majority of these people, they don't seek healthcare services in right time because they don't have access, and telemedicine was very easy for them. And we have seen that during the COVID time, telemedicine services, service utilization was the demand was increased by 40%. So I think that we should leverage on this demand, and this could be, we should build on this for other diseases as well, because this is this could be utilized for other infectious diseases as well.
Thank you. I mean, I remember hearing stories about people worrying about burials, and they didn't want to report COVID in case they died alone in a hospital. And they said, I'd rather die at home with a proper janaza. So simple things like spiritual, religious beliefs, social, cultural practices, I think are important in our context. So I just wanted to, because from our research we found that. But I'm going to now open it up to the audience, because I think we've heard from three different sort of speakers who are, really had a lot to share and contribute, and have clearly done a lot of work around this. We've got a number of questions. There's a lot of light, so I'm going to have to stand up. I apologize. So,
Sabina?
yes, Richard.
Please,
You're
if
still
there are any
here. You haven't
questions-
left us. Yes, Richard.
Yeah, if there are any questions, I'm afraid I have to leave now, but please, if there are any questions for me, please
I'll
list them,
find
and I'll
you.
be happy to.
I'll find
to,
you, and I'll send it to you,
Okay.
and you'll have to
All right.
respond.
Thank you both
Bye.
very much. Thank
Bye.
you.
So I think we've got questions now for Morseda and Tasnim. How can the Global South best position themselves to influence Global North policies with their rapid, frugal infection control methods? I think that's an excellent question. Can we keep it brief and give you responses? Morseda and then Tasnim? Morseda, did you want to have a quick go?
Yeah, I think the Global South's frugal innovation was use of community health workers and investing in prevention was the first thing, and rapid vaccination, and together with working with government, where early screening and detection with at the same time telemedicine, spread of telemedicine, this all things really worked well, and building on these could be a lesson for global north, because prevention is something which is I think is the best for all sorts of communicable diseases, where every country should invest.
Yeah, thank you. Tasneem, very quickly.
I think one thing that can work is to show them what policies work in Global South. I think we've done that during COVID, where the Global North was quite late in picking up mask wearing as a preventative measure, whereas South, or countries which had previous experiences with flus, were quite quick in adopting mask wearing, and it worked quite well. So quickly adopting policies that work and then research to show that it actually works can help position Global South to advise Global North.
I fully agree. Is there any more questions? And this is all new to me. It's very high tech. It's very nice. At Dr. Tasneem, telemedicine has been difficult to roll out in Bangladesh. Do you have any advice on how we should approach frugal health tech interventions?
That's an excellent question. I think telehealth has the use of telehealth has increased during the pandemic, but also the challenge has been to reach people who do not have those smart devices or internet, or people with low digital literacy. I think we have to keep this in mind, that we need to reach these segments and try out innovative solutions. Maybe for elderly people who are not very familiar with receiving these video calls or setting up, we can train our community healthcare workers or train the caregiver to sort of assume a mediating role. And also, in terms of testing out solutions, I think I'll echo what Shamarnabad said in a panel earlier, that for us not to be paternalistic and really try out different solutions and listen from the people who we are trying to reach and we are not able to reach through our mainstream telehealth solutions.
So I'm just going to take one more question. I know someone else can talk to you directly about how to share authentic health information, but someone is asking about online, behavioral change communication messages versus, in person in low-income countries. What do you think?
I think both can work, and both can work in tandem. Sometimes where in-person can not be scaled, especially in low-income countries. Digital can come in and supplement and can help us do more with less. Especially during the pandemic, lots of people stayed physically active through online interventions, through arranging online groups. So I think that can sometimes be the mainstay and sometimes supplement in-person support, but I think we'll have to go with a hybrid model here as well to get the most optimal outcome.
Thank you, because that also includes people who don't have access. I just wanted to wrap up. I want to say thank you. I'm not doing the 3 hours, despite BRAC insisting I go to midnight. I can't do it. I just want to congratulate, actually, BRAC, but also the speakers, because I have been really inspired. COVID has been a long kind of mental, emotional journey for many of us, and I really learned a lot today. I always wonder, we've got so many amazing innovations in this part of the world, and I think we need to communicate in every form, videos, platforms, webinars, seminars. Wherever we go, we need to share publications, peer-reviewed publications, conferences, because we really have a lot to teach the world. And it was an honor to be part of this panel and to speak to all of you. Thank you, Morseda. Thank you, Richard. And thank you, Tasnim. And thank you, Asif and colleagues from BRAC.